would also like to extend a warm welcome to all of you who chose to be here and prioritize this over the football game. It's really wonderful to see both familiar faces and new faces in the audience. I actually first interacted with Louise when she was taking care of my grandmother, as someone who works as a geriatrician in the Care at Home program. My grandmother was one of her patients, I think, in the late 1990s. And with that, I started to learn the power of having someone who has a geriatric lens of care. And you're going to hear a lot more about that as we go through the discussion this evening. Louise Aronson is a leading geriatrician, writer, educator, professor of medicine at UCSF, and the author of the New York Times bestseller and Pulitzer Prize finalist, Elderhood, Redefining Aging, Transforming Medicine, and Reimagining Life. Her current work focuses on expanding geriatric care and public perceptions of old age to more accurately attend to the decades and diversity of elderhood. She is developing innovative programs and practices to empower older adults to retain agency and maximize wellness as they age. A graduate of Harvard Medical School, her writing has appeared in the New York Times, The Atlantic, Washington Post, Discover, Vox, The Lancet, and the New England Journal of Medicine. She's been featured on The Today Show, CBS This Morning, NPR's Fresh Air, Morning Edition, Politico, Kaiser Health News, Tech Nation, and The New Yorker. She is currently on sabbatical and spending a year as a fellow at the Center of Advanced Studies in Behavioral Sciences at Stanford University. Please join me in a warm welcome for Dr. Louise Aronson. I want to talk a little bit more about what is a geriatrician. And in your book, you talk about a survey that was done where people were asked, what is a geriatrician? And someone apparently answered that a geriatrician is someone who serves Ben & Jerry's ice cream. So I know that this is a much more educated audience, but could you help us understand what exactly a geriatrician is? How is a geriatrician different from a primary care physician or an internist or a family physician? And then maybe share a little bit about your career pathway into geriatrics.
Okay, well, first, I just have to acknowledge that it's hard to compete with Ben & Jerry's. So my answer is not going to be as interesting, but it does speak to the fact that people really haven't heard of geriatricians, and that's partly because there aren't so many of us, and there aren't so many of us, we believe in our biased opinions, is due to ageism. So we are specialists in people who are older, the way a pediatrician is a specialist in someone who's younger, and the way an internist is a specialist in adult medicine. I think, even children can look around themselves and note child, adult, older person, right? And somehow we seem to think that the same doctor in this era where, what is it like, there are 8,000 new journal articles a minute or something insane, although now we have AI, so I guess it won't matter anymore, but that's a different discussion. Anyway, that you're supposed to know enough to care for people equally well at ages 20, 50, and 100. And that turns out not to be the case because people's bodies, their priorities change, how the body handles medicines, what can and can't be done, should and shouldn't be done, what to prioritize in a visit. So an internist, for example, might be adjusting your blood pressure medicines and scheduling your colonoscopy, and the geriatrician might ask you what's bothering you most. And it might be that you're having some trouble with incontinence, and it's meaning you're not going out, and that means you're walking less, and so you're becoming more frail, and also you're not enjoying your life. So yeah, your blood pressure might need some adjusting, and we can do that too, but we're going to think first about what do you need to have a meaningful life, and that may start with your continence or getting you some strength training so that you don't have to be afraid of falling. So we really think about the person and how they can best do what they need to do, which ideally is making the body work better, and sometimes is finding ways of changing the environment, physical or social, so that the person can still do what they want to be doing, just maybe a little differently than they used to. And you asked how I came to be a geriatrician, and it was that I was an internist. And what I found was that I and my colleagues were not taking as good care of older patients as we were taking of younger patients. And we were making mistakes. And it turned out there was a subspecialty where people actually could spend more years learning how to take better care of older people, and that it didn't have enough people in it, so it seemed like I could both do a service to my patients and also become something that was much needed in the world.
Great, thank you. So we titled tonight's event, A New Vision for Old Age. After writing your book, studying elderhood, and treating older adults as a physician, how would you summarize your vision for older adults? That is, if we were starting fresh, discarding biases and norms, how do you wish we viewed and experienced elderhood?
Well, I guess I'd say that there are these three main life stages: childhood, adulthood, and elderhood. And I would bring the same sort of creativity and innovation to all three stages. I also think that we should invest, maybe not equally, because if you do something equally, everybody gets the same thing, but with equity so that everybody gets what they need. I mean, currently it's a very adultist nation, so kids also are, hungry an obscene proportion of the time, or do not have access to services. We really center on the adult, when in fact, there is childhood and there is elderhood. The prejudices for elderhood are greater, but some of the economic biases are pretty bad for children as well. So, from medicine to all of society, when we're building a park, when we're building a restaurant, when we're doing anything, how do we make this accessible to everyone, unless it's, a playground for people under age 7, or something, then it's okay to focus just on children. But I really think it's bringing the same attitude that all stages of life have pros and cons. And I'm not saying, when you get very old, do the cons start to really be screaming at you? They do, so I'm not minimizing that. But if we think of elderhood as the third major phase of life, that's a period of decades. And studies across the planet have shown that most people have greater happiness, greater life satisfaction, and less anxiety through most of the decades of elderhood. There does come a period where illness and disabilities, losses of family, loved ones, friends, may tilt that the other direction. But to say that all of elderhood is its hardest moments is kind of like saying all of childhood is, what happens to you before you turn 2. It's a part of it, but it's not the whole picture.
I think your book does a great job of helping people to think about some of those perceptions and biases. It definitely did for me. So I understand that you've attended to both of your parents as they've aged, and both have experienced a variety of illnesses and geriatric syndromes. And I know your mom actually spent some time here at the San Francisco campus for Jewish Living. If you're comfortable sharing, what have you learned from your parents' experiences? How do you balance being a daughter and an expert in the field? And with that, how do you have any recommendations for those of us who are non-geriatricians?
Oh. Hold it closer. Okay, sorry. Sorry about that. So both my parents actually spent time here, although my father has been dead almost 11 years now. I think you learn things from being a family caregiver that you don't learn as a doctor. And that's really important. It's not that you can't have empathy and imagine into other people's experiences, but some of the practicalities, when you're the clinician, you're not doing things that maybe someone, that another member of the team is doing. But when you're the daughter, you're often doing everything, right? You're the home health aide, and you're the physical therapist, and you're the occupational therapist. And I feel like it really made me a better doctor and probably a better human being, taking care of my parents. And one of the things that I'm still wrestling with, and I'll be interested if people have opinions, but I tend to think that it's, the world would be a better place if we took care of our parents. Now, this is set, unless, if they abused you, that is a completely different situation. But assuming they did not, even if you have some disappointments and abuse being very separate categories, I think it's a responsibility, and a lot of patients say to me, well, I chose to have my children, so I needed to take care of them, but they didn't choose to have me. But I feel like if we are generations and we choose to go on as human beings, then we all will have these periods of time where we need help, and doesn't it make sense to offer it when you can? It's hard, it can be frustrating, but it's enriching, and I think in the case of both my parents, it brought me closer to them and gave me insights into clinical practice that I didn't necessarily have. Now, on the flip side, does it really help to be a geriatrician when your elderly parents are sick? It really does, because you think of all kinds of things. It's really important to try not to be obnoxious, though. So I make a real effort, like unless something's going wrong or I think they're doing something just horrible, you try to just be the daughter. But I can also help and do other things with my parents that maybe other people wouldn't think of. And then sometimes the experience can help educate people who aren't geriatricians in how to get better care of people in addition to my parents, hopefully.
Great, thank you. You alluded to this a little bit before, but part of what makes old age hard is that we fight it, rather than embracing it as one stage in this universal trajectory that you mentioned already. You acknowledge that, like childhood and adulthood, elderhood has challenges and opportunities. And I'm wondering if you could share with us some of those upsides and how, as a society, we can do a better job of embracing some of the opportunities of elderhood as opposed to sort of just thinking about the downsides.
Yeah, I think talking about them. I mean, most of my sort of middle-aged friends, well, first, actually, I should say that it is completely normal, natural, and probably universal to lament your aging, right? So I'm not saying don't lament it. Like, I look in the mirror and I think, what happened? Anyway, so I think that's normal and natural, and I also think we can rise above for the good of everyone in trying to talk about the positives. So for the last, 20 years, most of the people in my age cohort have been incredibly stressed with kids and jobs and, ambition and too little time, not enough time for exercise, not enough time for sleep, not enough time for all of that. And then there comes a point in elderhood, and I am now 60 and sort of watching this happen to people my age, where you start to reprioritize. Now, part of it is that, you don't start moving more and doing some other things, you can sort of see what will happen. But I also think it's an opportunity to slow down, to say, maybe if these are my last 10 years, 20 years, 30 years, how much do I really care about getting that promotion or, having done whatever it is you do? Maybe you think it's more important to do the things that we know are important for health and well-being. Get enough sleep, move your body, have time to make yourself healthy food, to see your friends, to have hobbies and interests outside your work and responsibilities. That is a joy that comes more and more to people as they get older. I mean, it's also a bit of a burden. My mother, now 90, talks about how it takes almost the whole day just to do all the tasks she's supposed to do for self-maintenance, but not really the whole day, and most of them you can make quite enjoyable. So I think people travel, they work less, maybe they exercise more if you like to exercise, maybe you learn a new skill. I mean, all these things are terrific. Maybe you change up your career. A lot of people who made money will then start going into service. Some people who were in service will become entrepreneurs. Prior to the pandemic, women in their 70s were one of the two fastest growing groups of entrepreneurs. Now, part of that was due to ageism because nobody would hire them. And part of that was that they saw needs for things that nobody was meeting, and so they met them themselves. So I think it's an opportunity. It's kind of like, so until we started having child labor laws and the Industrial Revolution in the later 1800s, there wasn't a phase of life called adolescence. And now some people argue it lasts until their kids are 30 or so, right? So like 20 years. But we have this new extra 20 years or so in elderhood now, and what do we get to do with it? I think there are lots of opportunities there. And people, when they prioritize things that make them feel better about themselves as people or as bodies, and when they get to do more of the things they enjoy, are happier. Priorities also, as you see that finish line, become more clear. And when people live according to their priorities, they also feel greater life satisfaction. So those are some of the opportunities that seem universal. Now, in poorer countries, we still see these same patterns, a little less happiness overall, because it's hard if you don't have enough to eat, for example, to feel too happy. But the patterns are identical across cultures and for at least the last several decades while we've been measuring this.
Great. So what I want to do is shift a little bit from sort of that big meta-existential type of question to something maybe a little bit more practical. Right. So several of the anecdotes in your book involve the impact of large, complex medications that are prescribed for older adults. That's something that as physicians we call polypharmacy. Could you briefly share one of those stories, and then share with the audience how they might advocate for themselves or their loved ones to avoid some of the negative consequences of polypharmacy?
Well, probably my best story of this actually happened here. The polypharmacy did not happen here. The withdrawal of polypharmacy happened here. Let's put it that way. The person arrived. So this man came here, and we were told he had end-stage Parkinson's disease. He didn't speak much. He barely moved. In trying to get some history, I called his daughter, and it seemed that he hadn't had Parkinson's the year before. So Parkinson's is a very slow-moving disease. And you don't generally go from normal, actually he had been working, to completely, bedridden in a year. And it seemed like it maybe wasn't even a year. And sort of sorting it out, what I figured out was that he had been given a medicine for a stomach problem that is one of the very many medicines that is where the benefits outweigh the harms in adults, but the harms often outweigh the benefits in older people. Again, another reason to have a geriatrician or a geriatric pharmacist or somebody really thinking about the differences in the older body. And that had caused a side effect, which had been treated with another medicine, which had in turn caused another side effect, which had been treated with another medicine. And I was suspicious of this because these things have been well known. There is a list of medicines that one should think very carefully about giving to older people. And there are different probabilities of side effects in old age. And you could kind of look at his med list, and it was somewhat classic. We actually, at UCSF, we make up cases to do with the medical students, and this had a lot of features of one of our cases, but it had happened to this man. So we actually just started peeling back all the medicines, and I think after, some we didn't want him to withdraw, but within a couple weeks he was off them. He started talking, he started sitting up, we got him physical therapy, he started walking, he moved out of the building, he was in the K building, I believe. Oh, they all have new names. Okay, he was in a middle building, which has been renamed since my days here, but in a sort of unit for people who really need a lot of assistance. And he basically moved to what was then the assisted living wing. He got himself a girlfriend. He was elected to the residence council. He was fantastic. So, does everybody go to that degree? No, but really frequently. Almost whenever a geriatrician sees a new patient, we can think of at least one medicine that might be doing more harm than good. It isn't always, but we can usually think about whether this is the right combination of things for this particular person at their particular stage of life. So how might you do this as a relative of someone? I think ask questions. Sometimes, often, almost always, right? If you're seeing a primary care doctor, they don't have all that much time. If you can send a note, where that can be looked at separately. If you can ask if the practice has a pharmacist who could look at drug interactions, that's a good idea. I know I have friends who have taken to Googling, if you know, just for each one for side effects. The problem with that is that if you look up any medicine, the side effects are kind of scary, right? I mean, it might lead us never to take anything, which probably isn't the right approach either. So really thinking about if there are particularly concerning things going on with yourself or with an older person you love, and then maybe looking to see if any of the drugs on their list might cause that. And then just really asking questions and trying getting people to think about it. Time can also be helpful. Like with this man, he was doing well. They added a medicine. He started looking like he had Parkinson's. They added the Parkinson's medicine. He started hallucinating. So sometimes the time frame can make a difference. The last thing I want to mention is sometimes the culprit is something somebody's been on for years. And in that case, the medicine didn't change, but the person did. And we all know that happens with time.
Yeah, I think it's hard. I know that everybody wants to trust their doctors, but when things just don't seem right, that sort of asking questions, looking things up and advocating is so important.
And if you do it politely and say, look, I know they don't give you enough time, because that's true. Most doctors mean well, but the system now is terrible. So say, look, I realize you don't have enough time. I am just really, really worried, and I need your help. Instead of like, I think you're killing my mother. You know, that doesn't go as well, even if you feel that way.
So you are the third speaker in this series for this year. And at both events that we had in the fall, both with Dr. B.J. Miller and Dr. Rebecca Sidori, our audience had really important questions about caregiver strain. And I think there are probably folks in the audience who also heard the NPR segments recently on caring for the caregiver. It was very much focused on caregiver strain, as we had talked about in this audience, or with this audience in the fall. So if, as you suggest, we are to look at elderhood differently, how might that shift in perspective actually affect caregivers? And then what can institutions like ours do to better support caregivers?
Ooh, well, I mean, we need a societal shift, right? This isn't about institutions. This is about society. You know, most caregiving has been done as free labor, mostly by women. Now up to 40% of caregivers, depending on who you're talking about, can be men. So men are doing better. And hopefully this will lead us to policies that enable men, women, all people to have paid leave to provide care, to have the time we all need, because it behooves everyone. But that doesn't help us right now, right? All that is to say is, vote in terms of caregiving. Let people know that caregiving matters. We saw in pandemic, and again, it was more women than men who had to quit their jobs to teach children, to take care of older parents. And then there are all those people who couldn't afford to quit their jobs, and what happened to their children and their parents. So what can you do as a caregiver yourself? I think I sort of talked about this a little bit earlier, in that if it's an expected part of life, and if in a situation that has not included a frank abuse, there can be an expectation of care, then we can all plan earlier who's going to do what. Not everybody will feel comfortable doing each part of things, but we almost always hear stories of, there's one child who's doing everything. Ideally, in families, we would talk about this before there's a crisis and really think about what people can practically do so more people are helping. I also think if it's normalized, if it's not something to be ashamed of, then you can ask your friends for help, or ask your children for help, or your grandchildren for help, or strangers for help. One of the things that we see that really helps caregivers most is having a place to vent. Now here, you could create caregiver groups, but it doesn't have the privacy or the anonymity of other groups. So it might be more effective to hook people into places where, say both spouses are here, or say, you want to preserve everyone's privacy and dignity, and people need to be able to ask questions and vent without having to worry that something's going to get back to someone else. So I think those outlets, giving people respite, breaks from things, but that requires having someone they trust with a person they love very much. So maybe there are certain people who work with, say if we're talking about residents with dementia, maybe there are certain caregivers who are particularly good with certain people, so that trust develops in all directions. I think often with dementia, one of the hardest things to learn is that the same good strategy may work really well on Tuesday and be a complete disaster Thursday. Anybody who's done this knows, right? But that works so well at not working today. So making sure people have a whole host of strategies and that one person isn't left responsible for using all those strategies, so that the aides providing the care, the nurses providing the care, the family members and friends all get similar training and know how to hand off when they're feeling they just can't cope anymore, and also know how to try something different, because that really makes a difference. Knowing how to communicate with someone with dementia, knowing how to provide care with someone who is cognitively intact but needs physical help in ways that preserve dignity, and let the person help. I mean, I think another thing that goes wrong is wanting to do it because maybe you can do it better or faster. And so for us as caregivers to take a deep breath and just say, like, hey, it's going to happen when it's going to happen. Does it really matter if the pants are on in 2 minutes or 10 minutes? It really doesn't matter. Occasionally it does, but usually not. So really getting down to practical. So communication, support, breaks, and skill learning. Because one of the hardest things about caregiving, and this has been proven time and time again, is that people are left to do it with no training in some of the things, some of the key aspects of it.
I really like what you first said about just normalizing things, and being proactive, and then having this sort of menu of strategies. I think makes so much sense.
Well, because really all of us will be caregivers unless, the vast majority of people will be caregivers. And it might be that some people who traditionally haven't been should be also. So let's train us all.
Totally agree. So I have a couple of questions just about the writing of your book. You title each chapter after a developmental stage, and I'm just wondering, sort of as you were writing the book, sort of what your thinking was about that.
Well, so I looked at all these doctor books, and I kind of mapped them out. This is one of the things a writer does when you're like pretending you're writing, but you're not writing, and you don't know if you're procrastinating or if this is actually helpful. But so I looked at all the doctor books, and they all had sort of between 9 and 13 chapters, and each chapter was about 25 to 37 pages. And so I started to write that book, and I was about 3/4 of the way through, and I was so bored. And I thought, well, if I'm bored, like, who's going to read it? So I sent it to my agent and editor, and they were like, great, keep going, but I really didn't like it. And I think I didn't like it because elderhood is complex. Being a human being is complex, right? And so to have this sort of straight line through topics didn't seem to do it justice. Whereas to mix the history and the medicine and the stories together felt more true to real life. So then I needed like an arc, like a way to guide myself and everyone else through the book. And it occurred to me that maybe the best way of doing that was because I had been through a huge host of attitudes about aging. So although those developmental steps are the ones we all go through, sort of, I don't know, I think I started with infant, toddler, child, for childhood, et cetera, and went through, what I really meant was my attitude towards an appreciation of old age. When I was younger, I didn't really think about it. People who were 50 were old, right? I mean, you start at a certain place. And as I got older and then as I got more experience, it changed. And I wanted to do that as a way of welcoming everyone into the book, because I think we all go through different phases of attitudes about aging, and they're all okay. But a good goal for all of us, and this is something I still work on all the time, is to keep reframing and not letting the internalized ageism that is such a part of our culture tell us, make old age a self-fulfilling prophecy of doom, because it absolutely doesn't have to be. So the arc is supposed to be our arc through not knowing much to learning and learning more, and then having certain adultist attitudes like, you old person, me here to help, and then realizing like that's actually not so helpful usually, and appreciating people's full humanity as they move through the stages of elderhood, and then getting there ourselves.
My other question about the writing is just how do you balance being a physician and a writer? That's not necessarily an easy combination.
No, so writers will say you have to read every day and you have to write every day, but if you're a doctor writer, there's no possible way that you can do any of that. Like that's just, I tend to go in phases. Generally, for me, it entails getting up really early and writing before I become a doctor, because I feel very strongly that when I'm a doctor, I'm a doctor. I'm only a doctor. I'm not thinking like, well, okay, every now and then somebody says something and I think, oh, please let me remember that later. But since I never do, now I know to not even think that. Yeah, I mean, they have to be separate. Doctoring takes a lot of you, and creativity for me happens more in the early morning. So usually it's something that happens before work, or on Saturdays. We have a rule in our house, I can work until a certain time of day if I'm in a writing phase. And what I tell our students also is that you have to acknowledge life. If you're going to have a busy career and if you have other responsibilities, then you have to know that sometimes you're not going to write, and hopefully sometimes you are. I do think academic medicine is an advantage in that respect because it has sort of moments where you're busier and moments where you're less busy, and might write an article or something like that. So, I mean, my books came out a lot of years apart. When I signed for the first one, they said, could you have the next one out, to us in the next year before this one comes out? No. Not possibly. I mean, even if I had nothing else to do, I'm not sure that I'm the person who would do that. So absolutely not. Yeah.
Great, thanks. So I want to talk about hearing aids, which comes up quite a few times in your book. And studies have found that untreated hearing loss can result in earlier cognitive impairment and dementia, in depression, but it can be hard to get hearing aids paid for. And many people are reluctant to admit that they need them. There's stigma associated with them. So I'm curious how you discuss hearing aids with your patients or your family members. I know I just had a conversation with my aunt and uncle about hearing aids on Friday night. And what is going on from an advocacy perspective to help with payment for hearing aids?
Well, actually, the Dementia Association, which has only sort of been more public knowledge in recent years, has made a huge difference. It used to be very hard to get people to wear hearing aids. It's another one of those things that says you're old. Not to be unkind, but when you're not hearing, that also says you might be old. It's kind of, it's a mixed bag. I think one of the big problems with hearing loss is that hearing aids are not like glasses. I take these off, I really can't see a thing. I put them on, I see quite well. Hearing aids don't work like that. And so people will speak to their friends who have hearing aids, and some will say, I don't know how much it's helping. What has helped more than anything, like hands down, is this association with dementia. Now, is it proven that hearing loss causes dementia? No. There are associations both anatomically for the region of hearing loss versus some regions of cognitive loss, and between people with hearing loss maybe progressing to cognitive decline more quickly. Interestingly enough, people with hearing loss also tend to have physical decline and mental health declines. Now, that's probably because if you can't hear, you have less strong social relationships, and maybe you're not inclined to go to a restaurant because you really can't hear a thing, and that can lead to depression and less going out and less moving around. So it has lots of negative consequences, but in telling people, look, there's this association, And if cognitive loss is one of the things you fear, I strongly recommend you get a hearing aid. We don't know for sure that it helps, but we know the absence of it hurts. That has really led people to get them. There are now over-the-counter hearing aids. That has made things more accessible. But it is a big problem, and this is another inequity, that at the same loss of hearing, a child will have hearing aids paid for, but an older adult will not. So another place to think about your votes and your lobbying. Let's see, what was the other question? Let's see, how do we convince people to do this? It's really, the dementia thing is huge. If people can't afford them, thinking about layaway plans, because it really is something that will help with brain and body and overall well-being. So it's a good investment if you're in that in-between category. And you can pay for it slowly over time. It's not an ideal world. Should Medicare cover it? Absolutely. Why do they not cover it? Because so many people need it. Think about it next time you vote.
Absolutely. No, thank you. And just, we'll just circle all the way back to my grandmother. This played out in spades with her, not being able to hear.
I also find with my mother, I have to mention that they work better when she's wearing them. Yeah.
Yes. What is it like to be a geriatrician thinking about getting older?
Well, I was just saying this to someone before the talk, but a few weeks ago, it occurred to me that I might lose my legitimacy, because I sort of feel like when you're a younger person advocating for older people, you know, it seems like, oh, you're doing this selfless thing. Whereas now with the gray hair, they probably just think I'm advocating for myself. So I'm wondering about credibility these days. So that's one aspect, not that I'm going to stop. I think it teaches you even more than your parents getting old teaches you. You know, like I somehow, this is really embarrassing, but I think I somehow thought I would be 35 until one day I was 75. And you know, this flies in the face of everything we know and everything that happens to other people. So it does surprise all of us. We imprint on ourselves as young. And we're met with youth so much in our culture that it is a little surprising. On the other hand, it's also kind of fascinating, and I'm getting to the point, so that the U-shaped curve of happiness, which I alluded to before, says that we're happiest in youth and then around age 60, and I'm on the uptick. And so I'm getting kind of excited about that part. And I also think it makes me realize the things, as I start to have to do things I advocate for other people, I can think more precisely about what might keep you from doing it. Certainly pandemic had me not doing many of the right things, and I think there's a degree of humility and empathy that is helpful, that you can imagine yourself into somebody else's life, but as you start living it, there's power and a deeper or different sort of knowledge there that I hope to put to good use as I develop more of it.
That was such a great and thoughtful answer that I think that this is a perfect time to transition to some questions from the audience. And I'm going to turn things back over to Stacy Lewis to facilitate the Q&A.
Okay, and back in the sound booth, can we turn the house lights on so we can see our wonderful audience? Thank you. So we've got some time for questions, and if you want to put your hands in the air, great. And I'll just hand you the microphone so that you can address the doctors yourself.
So you talked about having a geriatrician. Is that in addition?
Closer to your mouth.
Is that in addition to a primary care physician? Or does the geriatrician become your primary care physician? And one other question, I know you work in the UC system, so how does it work at UC?
Oh boy. And we're being recorded. Okay, here we go. Geriatricians a lot of geriatricians are primary care doctors. So you know, in an ideal world, or let me be more specific, in my ideal world, we would have a pediatrician and then an internist and then a geriatrician. But because there aren't enough geriatricians, that is rarely possible. So what we're trying to do at UC a little more is to create consultations where we can support the internist to take better care of the older person. I think on a national level, if this many people in childhood or adulthood did not have access to the sort of clinicians specialized in their care, there would be huge amounts of resources put into training people into geriatrics. There would be loan forgiveness. There would be incentive plans. There would be all sorts of systems. But we don't have those yet. So at this point, at least trying to find someone to do a consultation or to see you periodically is often the best bet. In the UC system, we have one geriatrics clinic. We've had the same practice since 1995, I believe. It has not really been allowed to grow much. In fact, and they don't keep a waiting list. They don't keep a waiting list because they can't do anything about the waiting list, because there is no interest in expanding the practice. So they don't keep a waiting list. They, in fact, contract who's allowed to be seen in the practice. So right now, you have to be a San Francisco resident. They keep moving the age group up. So it started at 65, it went to 70, it went to 75, it went to 80. It's either 80 or 85 right now. Most people have to have a dementia diagnosis. So you can see how it narrows and narrows and narrows. It also, I think, creates a huge problem for geriatrics, because as it becomes associated exclusively with the oldest and frailest, it seems like a small niche specialty, and that makes less people interested. So you end up in this vicious cycle that goes only downward. Whereas if you had people taking care of older people, and also, what do we want for ourselves? We want to prevent as much as we can for as long as we can. If we wait until you already have dementia and are in your 90s or whatever else, then yes, we can provide you outstanding care, but we may not be giving you what you wanted most. So I think it's a huge problem on all levels, and it's very hard to get into any practice. Literally, I think a week does not go by that we don't get asked, can you get someone in here? Do you know someone in Spokane? Do you know someone in Amherst? Do you know someone, in Virginia? And we might know someone, but the chances of them having openings in their practice are basically nil. It's a crisis.
In the back, Isabel has a microphone. Yes.
So you strike me as somebody who is open to being a disruptor. So how would you suggest that we help you disrupt so that somebody who is in their 60s or 70s could have a geriatric doctor, or about medical schools? Is there a way to say that isn't okay, and what we could do?
Thank you for the question. I wish I were a better disruptor. I seem to be able to do it like when I'm at my keyboard better than like launching a movement. I need to work on that. Maybe that'll be my next phase. But what I think everyone should be doing all the time is writing whatever health system you're in, because this is true at California Pacific, this is true at Kaiser, this is true everywhere. Just keep writing them. Why is it you have pediatricians for kids and internists for adults, and I can't get in to see a geriatrician? Why is it you're letting me get worse before I can see a specialist in the problems that are bothering me now? Like, I have been at your health center for how many years, and I'm not getting the care I need. What are you doing about this? Think about it with politicians, too. One of the problems with old age is that you will see people lobbying greatly for their geographic area or for children's issues, but you don't see people too often lobbying when they're, or actually, people will lobby for issues of their interest group, except for in old age. You don't see, and this is ironic at a moment of so-called gerontocracy in our government, that you don't see the older members saying, what are we doing wrong for older people, and what policies could we enact? Instead, what they're doing, and what we've created a society that kind of makes it necessary, they're dyeing their hair, they're getting sprayed with that stuff that makes their skin glisten, they're having things tucked and plumped and, all this sort of stuff so they don't look like the old people they are, instead of lobbying for themselves and the other people who are old with them. So I think, when people are standing up for older people, support them. You know, if you can send the money, send the money. If you can campaign for them, campaign for them. But at the level of your individual health center, get you and everyone else you know to frequently send notes and say, look, you're not providing a service I need. What is it about the geriatrics clinic that, you know, it's been there for now, what is it, like 28 years or something, and you don't have a wait list? So how do you even know how big the scope of the problem is if you're not even tracking numbers? That's not evidence-based medicine.
Okay, the man in the back, and then we'll come back to the front.
Thank you. My question has to do with relationship between residents here and their adult children, and things where the adult children start behaving like the adult and treating the parent like the child. Example one, taking the car keys away, or deciding where you go or who your friends should be. You know, how does the senior deal with that?
I love that question. Thank you for asking it. I think you have to sit down and have a serious conversation. And say that you are an adult and you're able to make your own decisions about friends, et cetera. Now, driving can be an issue. We tend not to retire from driving when we should. And I'm saying this on a big scale because it happens a lot. Soon there may be laws because we are doing such a bad job of regulating ourselves. But I also think coming in and just taking the keys away is not the best approach. You need to think about other strategies. How is this person going to get around? What else can we do to be helpful? Because otherwise you do make a life so small and narrow, and that's why people don't want to give it up. We've also made it so it's a rite of passage, right? When does the teenager feel like a real adult, right? It's that 16 and you get your driver's license. But we don't have a similar ritual for the other end, or we don't have the services people need. In terms of your own kids, I would say, hey, look, I need to talk to you about something serious. You know, it makes me feel infantilized, and that doesn't feel good, and I know you mean well, right? I'm not saying this as criticism. I'm saying it's hurting me, and it's a problem in my life. If you think we need to discuss something, let's discuss it. And then you have to be willing to hear, because maybe, you know, you didn't see someone the other day and nearly hit them. I had this happen with my own father, and then I spent a very long weekend having conversations and trying to get him to a point where it was his decision. It's a hard thing. With my mother, who saw this, she realized it was coming, and she started practicing taking the bus or having someone call a lift or asking a friend for a ride. So it has to be a two-way street. You have to realize that there might be areas where safety really has to be the decision, because nobody wants to kill someone driving their car. I actually have a visual thing, and I no longer drive at night. I no longer drive in the rain. You just picture yourself hitting a human body, and it's easier to make limits, even though they're hugely inconvenient for yourself and everyone who drives you around. So you do that part, but then you also have to get the kids to say, look, it's my life still, right? There's this constant tension between the adult children prioritizing safety and the older person prioritizing pleasure and life. And say, look, would you like this if I were doing it to you? I don't like it either. We need to talk about it. And if you can't have that kind of conversation, and not everybody can, it's a great idea to invite someone else in to be the mediator. Maybe it's a good friend. Maybe it's a friend of theirs. Maybe it's a friend of yours. Maybe it's a social worker or someone here. But I think you have to just sort of announce it. Sometimes giving them time to respond first, like send an email and say, I'm having this problem. I want to give you time to think about it, but then let's make a moment where we're going to talk about it. And I think that's the only way forward. And both sides have to give a little, usually. I don't know your specific situation, but I know that no one likes being made to feel like a child. And that's the key message you have to send. It doesn't feel good. I know you mean well, but we need to find a different way to deal with things.
That was such a good question and answer. Thank you. Okay, I saw some hands here. Kathy, we'll go to you next.
I'm curious about your vision of elderhood institutionally, what would it look like specifically in terms of legislative policies that you would recommend across the board? Let me give you an example of what I was thinking of. I was thinking about parks and recreation in San Francisco. There are parks for kids under 2. There are children's parks, and then there's exercise equipment for adults. But what would it look like if you would address exercise needs? Similarly, in architecture, what would be user-friendly? Like the doors here are impossible. They're fire doors, but we can't move them. You know, across the institutions, what would it look like, for example, in movies? I mean, there's increasingly films that focus on older people, but that's recent. So what, do you make legislative recommendations in your book or in your work?
I talk somewhat about that. I do talk about what I call silver architecture, which is designing with older adults in mind. Silver may not be ideal, but you know, green already had green, and so anyway, sorry if you hate it. It does get the message across. And silver is a precious metal, so. So yeah, really thinking about that when you make things. I actually have a talk I give fairly often which shows the playground. I mean, you basically gave a version of my talk. There are some wealthy suburbs that are now putting in areas where older adults have specific equipment too, right? So things where you can safely work on balance, where things move, but there are things to hold on to on either side. That same stuff they now put on playgrounds for kids so the kids don't break bones when they fall. Those work as we get older, too, to prevent fractures, right? And, you know, the kid, you put a cast on it, and, you know, and the kid is better in like, a month. It's way different. So there are, you know, you could have, well, pickleball actually started with older people thinking, oh, we don't have to run as far, and now everybody's doing it. But there are such things as parks like that. So in an ideal world, legislation would say, just as we have, you know, disability access or, you know, access for kids and adults, you would also have an area with things that would specifically enable older people to play, to have fun, to work on fitness, and similarly with buildings. I mean, fire doors are a huge problem. I actually just I took my mother to a clinic at UCSF a couple weeks ago and wrote an op-ed about this because the bathroom door, this was specifically a clinic for diseases that only older people have, and there were lots of people with assistive devices, and you couldn't even open the bathroom door. I mean, you know, I could just see her being crushed. Anyway, so somehow the fire people have to speak to the age people, and if you're going to have a door like that, it has to be very easy to open with one of those things you can hit with your elbow or your hand. I mean, you shouldn't otherwise be able to have a fire door. Especially in a facility where everybody's old. So yes, I think we need policies. This is just the architecture part of it, but in every situation, if you're thinking about populations, think about the whole population. We are seeing more of this because boomers are, you know, we had the great and silent generations, who were great and very silent, and the boomers are anything but, right? So the 60s happened because they made noise, and now they're making noise again. So things will change, but the more noise people can make, the better. Another area we have to think about, though, is retirement, right? Because that's where people are like, on the one hand, we have these healthier years, and working just as hard doesn't seem so attractive as you feel more tired. And on the other hand, having arbitrary ages when people can keep working don't make sense. You know, so I think we really have to think about retirement. Like Social Security was set at 65 when the average age of death was 67. So we might have to think about those policies, and they might require some give and take also. But maybe you don't work 50, 60 hours a week. That would be lovely. I look forward to that.
Okay. Yes, Jan. Oh, can we pass the microphone to Jan, please? Thank you.
Hi there. I have not done too much reading about the geriatric senior moment, you might say, or development, and I have not read your book. But what I'm trying to figure out is how can you empower us, because we're of the age where we may or may not see the kind of development in the geriatric world when the time that we need it. And so the question to you is, where can we find information that would allow us to sort of check things off a list, you might say? We do it when we're younger, you know, you have the right vaccines, you try to eat right, you try to get the right amount of sleep and all those kinds of things. But I'm just curious, is there some way of learning the things that the geriatric person would ask you to evaluate your health? I mean, looking at it from my side. Do you follow what I'm saying?
Yeah, I think so. Sort of resources so you know what you should do next, right? So there are vaccine schedules, and that part the internist gets well. You know, they're like graded on those things, so they do them well. More important are the things like, how do you keep yourself from falling for as long as possible? How do you make sure you're continent? How do you keep your brain healthy? How do you keep it so you can keep doing what you want to be doing as long as possible? There are sort of two different literatures or sets of resources for that. One is kind of from the geriatrics area, and if you look at the Health and Aging Foundation, which is run by the American Geriatric Society, they have some information, but they do tend to focus more on older people. Then there is this whole sort of movement. Some people call it anti-aging. I have trouble saying those words because, like, if you're anti-aging, you basically want to die at, I don't know when, 50? You know, it just doesn't seem attractive. 40? Yeah, I mean, you know, 20? I mean, you know, you develop and then thereafter you're aging. So it just doesn't seem like a good plan. And it's also like, usually we're like against racism. We're not like against, anyway, it just seems problematic. But there is sort of a longevity, healthy aging movement. The difficulty there, so just as the geriatric side of it tends to focus too much on the later stages, the difficulty there is that there's a huge market for it, right? Because so many people are in the situation you're in, and because we have made old age so fearsome that people are willing to try anything. So mixed in among, you know, with some very good science is people selling all kinds of snake oil that they say will be helpful. There are people who say they can reverse your dementia. It'll cost you $40,000 a year, and if Medicare covered it, it would have gone broke long since. There's also the other little matter that it actually doesn't work. The person cites studies that were rejected by all peer-reviewed journals and were in pay-to-play journals, and they can't be replicated. So there are people like that who make a lot of money and get a fair amount of publicity. There are some others who have some decent advice. People who will talk about the fundamentals, because the fundamentals are the same at all ages. So it's movement, it's learning new things, it's eating healthy food, like nothing processed, lots of plants, you know, it's getting enough sleep, it's learning how to manage stress. But thinking about exercise in a way as an aging person, right? So a younger person, they do something great, although even for kids now, they don't diversify their sports enough and we get earlier injuries. But as you age, for example, you want to think about aerobic fitness. So that's for your heart and your lungs and also really good for your brain. You need to build muscle. We start losing muscle at 30. Right? So if you're starting at 50 or 60 or 70, you've lost a lot of muscle, but the good news is you can gain muscle. One of the studies that made me a geriatrician came out in 94, 95 in the New England Journal and took people at the Jewish home actually outside Boston, people in their 80s and 90s, and showed that they could build muscle and that when they build muscle, they could walk better and feel better and function better. And that means we can do it at any age, so it's never too late. So aerobic exercise, strength exercise, you need to do something in particular about balance, although working on strength helps, and you need to work on flexibility because things get firmer. So how can you find that out? Some of the aging resources can be helpful, but a lot, you know, if they're asking for money, don't trust them. I guess I would say. I'm trying to think of other practical resources. I just did read Peter Attia's Outlive, and some of it I don't agree with, but some of the basics on the fundamentals can be helpful. But he doesn't do a great job of different ages or different genders, in my opinion. So there are things out there.
I have one more question to all of this is, in looking at the male body and the female body. Are there differences in way they age?
Ooh, wow, that's a big one. Well, for falls, for example, the male center of gravity is higher, right? More shoulders, less hips. So when men fall, they're more likely to hit their head or die. Women are more likely to have fractures. So there are some differences in that. As we age, men die younger. And women tend to have greater burdens of disability from arthritis and other things like that. Sometimes men are, and this is not to talk about all men, but there are noted patterns of men not going in with symptoms as early. And so things are sometimes caught later. I had someone for women. Women's bones get thinner sooner because of hormonal reasons in part. There are a variety of differences. So does thinking about that warrant attention? Yes. But then things happen, like people think about the bones of women and they don't think about the bones of older men. And just because it happens a little later doesn't mean when the guy is 75 or 80, you shouldn't start thinking about it. So there are lots of things like that where we focus maybe a little too much on one and not on the other and don't appreciate the differences.
Thank you. We have time for 2 more questions. So, yes, you in the purple sweater, I think. I don't know where the microphone went.
Oh, me. Oh, thanks. Hi. Yeah, I wonder what your opinion on antidepressants for older people, and if you had any workarounds besides antidepressants. And I'm speaking for myself in my 60s and my mother in her 90s.
Okay. That's a great question also. So many good questions. This is a great group. So antidepressants can be very helpful for anxiety, for depression, for a variety of things. At all ages, it can also be helpful to get therapies of different sorts. Cognitive behavioral therapy is particularly helpful. If people have some cognitive impairment, it can be a little bit harder to engage in that. Sometimes using a bit of both. There are, in terms of antidepressants, there are several different categories. People sometimes have bad reactions to 1 or 2 categories and do fine with others. There are ways of guesstimating which one to try in a particular person. That usually has to do with using the side effects to advantage. So for instance, if antidepressant X is somewhat gives people diarrhea and the person has some constipation, then it could be a twofer. Right? So you think of things like that. Or this person isn't sleeping very well. This one makes them go to sleep. So let's try this one first. But we do now, there are some ways of doing blood tests for psychopharmacology blood tests to see whether people will respond more to certain categories of drugs than others. Not all clinicians send those, but they are available, and clinicians can sign up to send them. They're not perfect, but they can be really helpful. We've had patients who've tried lots of antidepressants. We then send that, we try one, and it's wonderful. If you don't want to use them, then again, it's those fundamentals. How do you, in addition to therapy, but how do you get enough sleep, because that's so important for mood? How do you get your mood good enough that you move and get outdoors and ideally in nature and do that? Maybe you need doses of that exercise 3 times a day. Maybe that needs to be a priority. How do you get off things like refined foods and sugars, which, feel great in the moment and are so comforting? I speak from knowledge here, and yet they do not help. So it's really a lot of those things. There are also some mind-body programs that can be really helpful. Tai Chi, yoga, people who will work with you with other modalities that many people find helpful. For your mother, the side effect profile is really important, as are the drug interactions. Sometimes a tiny bit of a couple of things works better than a larger bit of something that causes a side effect that's really damaging.
Thank you.
Thank you. Okay, last question. You in the front row. I will give you my microphone.
Thank you for the talk. it's disheartening to hear how limited the numbers of geriatricians that we have. Someone who doesn't have sickness above their head, looming mid-70s or early 70s, they have to wait until something happens before they're able to get in to see a geriatrician? Is that what I'm understanding?
Yeah, so she's asking if, say, you're healthy in your 70s, do you have to wait until you're much older and have more problems before you can see a geriatrician? And the answer is often yes these days. But that's actually not just a geriatrics problem. That's an American health system problem, because calling it a health care system is a misnomer to my way of thinking. It is a medical care system, right? It's about medicines and procedures largely, and it's not about maintaining health, it's about treating disease. So the whole thing is skewed in that regard. All the dollars, each health system is incentivized. Like, it's the best for them if you can be in the hospital. They're now trying to put the outpatient clinics. Meanwhile, nobody in San Francisco can get a doctor, right? But they're saying, let's just have the outpatient clinics be in like Redwood City or somewhere else. So it's the entire healthcare system. So I do think healthcare, we have a lot as a nation to contend with right now, and so it might not be that in the next cycle of elections healthcare is way up there, but it needs to move up there because our system needs to, it is basically falling apart. It's something like 1 in 5 health professionals quit during pandemic, and there was just another report, 1 in 3 are now thinking about quitting, because the fewer there are and the worse the work environment is, the more unhappy people are, the more people leave, which leaves the burden on the people who are left, which grows even greater. So really think about healthcare advocacy. Like, for those of you who want like an encore career or something really meaningful that you can do for yourselves and everyone else, like, get out there, because what we need is a healthcare system. We need a system that actually cares to keep you healthy, and that is not what we have right now.
Louise, before we conclude, can you tell us, in light of that reality, what gives you hope?
Well, this is the great thing about being in an academic center, because the young people who come into medicine that we get to work with, and I'm not this year, but I'm usually on the admissions committee, I cry reading these folders, and like, you read some of the letters from people and I'm like, oh, I hope your parents know. Like, it just slays you. So there are some great young people coming in, and actually it seems a little bit like they might be paying more attention to old age than their predecessors. So I should just also add that be a good grandparent. Most people are. Most of my patients, it's their favorite job. But be a really good grandparent, because when you ask somebody who's interested in geriatrics why they almost invariably cite a grandparent. In my case, it was a grandfather. I think there's a lot going on. There's also this exciting area of geroscience, which may help with, whole new approaches to treatment, things that can help with frailty. And I think I'm hoping that baby boomers in their 60s and 70s are going to make enough noise, and that we can all be a part of that, that the system will change, and that we can partner with these really bright, really passionate younger people to make things better. But I also think older people need to be in that equation. We often put the future on the young, and I think the old can be part of the future too.
Thank you so much. Louise, we want to thank you for being here tonight, sharing your wisdom and humor with us, and thank you, Adrian, for facilitating. If you enjoyed tonight's conversation, I hope that you'll visit our website. We'll be sharing a link to everyone who's here, but our 2 previous events are recorded, and if you missed them, you can watch them. We're already planning for the 2nd annual speaker series to begin in the fall, so stay tuned. We have Louise's book, signed copies, on sale tonight where you checked in at the registration table, so stop by to get a copy before you leave. And thank you so much for joining us. We loved having you, and thank you for your great questions. Have a wonderful evening.